at the University of Miami. I just want to thank ISFGS and Dr. Rosenthal and everyone for having me speak here today. And as you can see, we'll be speaking a little bit about fluorescence, robotics, and artificial intelligence. Is this essential or just something that is optimal enhancement that we're adding on? So I think I have a clicker. I have no pertinent disclosures right now. And here's just a quick agenda. We don't need to go all the way through it, but just at a glance for you. So we should start with what is surgical intelligence, right? That seems like the most obvious place to start. And so here's three sort of higher level ways to sort of define it, and yellow is the most important, but using in data to generate objective, unbiased outcomes, right? How can we use data-driven outcomes to support surgical outcomes? And the most important is training machines, right? We train the machines, and how can they aid and advance human surgeons and the skills of those surgeons? And this is actually very real, and we'll go through a lot of examples today of what is actually being done in this field. So here's just a high level. So AI isn't just in one part, but it's throughout the continuum of the patient journey in their surgical journey. So all the way from preoperative planning through intraoperative guidance and even in surgical robotics. So it underpins the entire continuum of the patient journey. So we'll start with AI-based preoperative planning. So I know it's a busy slide, but I'll guide your attention. So about 500,000 labeled endoscopic images were used to train a computer-aided detection model. And about a little over 1,700 unique esophageal images, some that were confirmed to have an early-stage neoplasm Barrett's esophagus, others that were known to not have a non-dysplastic Barrett's esophagus were used to see if the model was actually effective. And so if we look to the right side here, so two identified neoplastic lesions. It generates a heat map where it identifies that lesion, and then it actually places a crosshair at the most abnormal part. And it's a dynamic adjustment that it does. And then, of course, after you need to iterate and train on the model, and so what happens there is it'll continually use endoscopic experts to continually establish ground truth and reiterate the model. So just a little background here. It's called a convolutional neural network. It's pretty common in the field of AI. And it's basically what it sounds like, artificial neurons. And it's sort of a simplistic way of looking at it. But if we start on the left, there's the data, image data in this case. There's input layers that sort of aggregate the data. And then throughout the hidden layers is where all the iteration occurs. So it looks at pairing of imaging and sort of compares that to the existing data points and then what else is put in by those endoscopic experts. And then all the way on the right side is the output, right? Is this non-neoplastic or is it neoplastic? So how did this actually perform? Quite well. You can see the numbers there. In fact, the system achieved a higher accuracy than any of the endoscopists that were tested on the same data set alone, except for one. So we need to find that one person. Okay, so AI-based preoperative planning in navigation for gastric cancer surgery. So in this case, there was 30 patients. They underwent a robotic distal gastrectomy. And the interesting part here is that we were able to take 2D imaging and CT and convert it to 3D imaging. So it's all numbered for you. So go into the CT scan, get a 2D image. That's a deep learning model reconstructs that into a 3D image. And then it's very unique to the patient profile, to their anatomy. And then the pneumoperitoneum is texturized for shading, contour, as well as more realism. And then that can actually be used for the preoperative planning process in a simulation environment, and then even brought intraoperatively. There's a tiny image to the right of number 4. That's taken from a different study, but it's interesting because what it shows is sort of an example of looking on the bottom, those 3 images of CTs, and then looking up at 5 different AI models that can actually create a 3D rendering of the anatomy that's very unique to those patients. So this is a video, but even if it doesn't play, you kind of get the idea here. So there is the anatomy of the vasculature, and then above is actually the surgeon using that, while they operate, so they're able to use it intraoperatively as well. AI-based intraoperative guidance. So we just kind of had a segue into intraoperative. Again, busy slide, but I'll guide you. So this is really about automating surgical subtasks. That is a world that maybe we'll see. So suturing, cutting, debridement, all of these things. How can AI help with that? Well, if we look sort of at the yellow box right there, so the features are matched from stereo imaging. There's a left and right image, and then the deep neural network, which is different than the convolutional neural network that I showed before, will actually will match the most close pairs of those images, put them through the deep neural network, and then create a depth map. And so what this means is they sort of want to track deformity of the tissue, right? Because this is happening in vivo, so the tissues are being deformed in real time during the operation, and AI needs to be able to understand how things are moving in space. And then finally, it does create a deformable tissue model at the end. You can see on the right where the actual tissue you can see is reconstructed in a computerized form right there with a heat map as well. So there's 6 degrees of freedom also that needs to be. So it's not just the tissue that's being deformed, but also how are the instruments behaving in this space. And so we have a roll, a pitch, a yaw, and of course an X, Y, and Z plane. So all 6 degrees need to be picked up, need to be interpreted by AI, and then integrated into the algorithm. So you can see the top image, the surgical scene is what's called pose estimation. That is the 6 degrees of freedom and is an estimation line of where the instruments are and how the tissue is moving. But then below that is a computer image that is generated from all the data showing how the neural network can actually identify the deformed tissue. So it knows where the tissue is being pulled, in what direction, space and time, as well as where the instrument is and how it's positioned, again, in any of those 6 degrees of freedom. And again, all this can be used one day to automate surgical subtasks if it knows exactly what it's doing. So there are excellent performances, of course. There are misdetections. That's part of the algorithm, but high computing power also associated with it. As we know with AI, it takes a tremendous amount of power to do it. Computer vision, very similar concept. This is the idea that computers will interpret digital images and videos, and it's being used today now to even calculate steps in surgery. So what step are you on? And the computer can actually read that. So we'll start with image classification. So first, what are we looking at, right? This is harmonic electrocautery. You need to know what you're looking at and identify it. And there's a little light bulb at the bottom, so each step doesn't have to be used. It doesn't have to be. There's 4 steps I'll show, and they don't all have to be used together. They can be used independently. So this first one, they use it to automatically, again, identify steps. Steps number 2, object detection. So now we know what we're looking at, but we need to see it in the actual surgical field. So you can see how it labels a harmonic in the grasper within the surgical field, and it places boxes and labels around that. Again, labeling is very important for artificial intelligence to understand what it is looking at as it iterates on the algorithm. Then there's semantic segmentation. So they need to know the difference between the actual instrument and the background. What is the anatomy? What is the instrument? And you can see that clearly, how it delineates it in red. And then finally, instance segmentation, which is if you have 2 instruments that overlap, it needs to recognize that they're completely different instruments. And also, to number 3, it needs to recognize they're not part of the background. Another interesting concept, we've probably heard a lot about this, is augmented reality. And so here's a really interesting case where they used a rapid localization of underlying anatomy for pedunculated flaps of the lower extremity. AR is actually quite interesting because it doesn't compromise operating room sterility at all. You can bring it right in there. It responds to hand gestures, voice commands. It really offers real-time information intraoperatively. And so here's some pretty futuristic pictures that you can see there. And so like I said, this was used for this flap surgery. So you can see how it was created into a 3D model using what's called the Microsoft HoloLens, which the surgeon can wear. And the next slide is pretty neat. So actually the surgeon is wearing this while they perform the operation. You can see the real-time overlay of what was generated by AI in the preoperative phase, and they're using it intraoperatively now to guide the operation. So it did achieve great reliability in the reconstructive surgery. And again, there is need for technical assistance and the enhanced tissue tracking that we talked about earlier. So we are at an ICG conference, so it makes sense to bring in AI and ICG coming together. So this was a specific study that sort of looked at how could AI and ICG be used together. So what there was 60 ICG colitis-associated colon cancers that were used both in the murine model as well as human tissue samples. And the way that this worked is AI was meant to detect whether the tissue was normal, dysplastic, adenoma, or carcinoma. And the way that it did this is, what was shown in the study is that inducible nitric oxide synthase has the strongest association for fluorescence, mainly because it is highly conserved in tumor cells, and it creates an altered retention of the ICG. So essentially, it turns off particular drug efflux channels and therefore holds onto the ICG longer than normal tissue. And as such, the AI model can actually detect certain tissues that are aberrant and different and tumors because it collects highly in those cells that express the INOS. And so it was able to identify that. In fact, in this study, all carcinomas, all of them had at least a 2-fold higher intensity in their ICG fluorescence, and 90% of adenomas had a 1.5-fold higher intensity. And the system was able to identify that using contrast brightness as well as what's called tumor to normal fluorescence ratio, where it looks at, again, what does a tumor cell look like against normal tissue around it, identifying the intensity of those cells, again, that express high with INOS. Another quick study here was sort of using AI and ICG again together to look at the loose connective tissue in a way to avoid bile duct injury. So you can see on the left, AI puts the LCT, the loose connective tissue, in blue, and then they fuse AI and the ICG together to help make a safe dissection plane to show you exactly where that is. And you can see the time is just a bit over a tenth of a second to do that, which is quite quick. So we'll move in a little bit to surgical robotics, right? Again, we're talking about surgical robotics and AI, but how can AI boost sort of the capability of surgical robotic systems? And so three high-level areas: surgical tools in the environment, system modeling and control, and then, of course, how does the human, the surgeon, interact with the robot? So a lot of the similar concept we discussed before: surgical instrument and tool tracking. Some of these images do look familiar. It's all going to be applicable to a robotic setting. But an interesting is the 3D suture thread tracking. Similar concept. It has to sort of understand how the suture changes in space and all the deformities that it undergoes when it's being used. And so all three of these things together can allow for automation of certain surgical subtasks. Generally, in surgical robotics with AI, sort of four big things here: executing specific motions, like we talked about, reducing surgeon tedium, actually learning from expert surgeons, so it can obviously pick up the motions and record how the surgeon moves and all of the steps and all the motions of the hands, and then, of course, potentially superhuman performance. So we'll see if that comes out at some point. So what are the benefits generally of surgical innovation? Well, improve patient outcomes, reduce risks and complications, right, and increase precision and efficiency, and shorter recovery times. So it's here. We've seen the studies, and it's going to keep evolving. But again, there are ethical considerations that have to be considered. So what about a risk of bias, right? What data sets is the AI being trained on? It's sort of a garbage in, garbage out. Whatever you give it, it gives you. So you need to be careful what you're putting into it so you get the most accurate output. Data privacy, right? Currently, a lot of the data that's being used is confidential patient data. To be very honest, it's sort of questionable where is that all being stored and what clouds and who's accessing all this data and what's the IT security around that. Human agency, is there really a replacement for the soft skills of a human, of a surgeon, of some of the more complex decision-making and clinical judgment skills that need to be made? And then, of course, accountability. If something goes wrong, who's at fault, human or AI? So there are definitely opportunities for improvement, right? Anatomical factors, we were talking a little bit about those data sets. And so can it recognize small structures, for example, tiny nerves covered by fat, things that are quite small that maybe an expert skilled surgeon might be able to detect? What about patient factors? Right now, does it have those rare cases? Does it have the aberrant anatomy? Or does it just have the run-of-the-mill case and the run-of-the-mill sort of patient? And then the third thing is surgeon factors. Well, does it respond to AI in crisis? What if there's massive bleeding, incorrect dissection points? How does AI react? Does it start to go rogue? Those are opportunities for improvement that need to be sort of addressed before this can really go into the mainstream. Thank you very much for your time. I appreciate it. Hope you enjoyed it.
Thank you, Mr. Weiss. Very nice information of the future integration of the AI, robot, and the fluorescence. Thank you very much. So the remaining two